So first, we have Catherine He.
Thank you for the opportunity to present our work. Cephalosporins are safe and considered first-line surgical prophylaxis for children with non-severe penicillin allergies. However, second-line agent use is common and is associated with increased surgical site infections, adverse events, and antimicrobial resistance. The objective of this study was improve compliance with cephalosporin prophylaxis through improved documentation and targeted educational efforts using a Plan, Do, Study, Act framework. A multidisciplinary team with representatives from allergy and immunology, surgery, infectious disease, and pharmacy created staged interventions to improve compliance. These included a decision support algorithm for prophylaxis use, caregiver outreach to clarify documentation, standardized educational resources for faculty and rotating trainees, email reminders with prophylaxis recommendations, EMR-based decision support, and root cause analysis of non-compliant cases. Rates of complete allergy documentation and use of cephalosporins as appropriate first-line prophylaxis were assessed for general surgery procedures between a 12-month pre-intervention and 14-month post-intervention period. 619 patients were included in the study. Rates of complete documentation improved from 57% to 84% after all interventions. Rates of appropriate prophylaxis increased from 37% to 89% following all interventions. And evidence of a staged improvement was noted with each stage of interventions. In conclusion, compliance with cephalosporin prophylaxis significantly improved following a multidisciplinary effort with documentation, education, and clinical support. While compliance improved substantially, it was not universal, indicating that further process improvement efforts are warranted. Ongoing efforts include post-operative audits within 24 hours to identify barriers and to improve compliance. Thank you for your attention. I look forward to your questions.
Nice. We have 1 minute for questions.
Your chance. You got 1 minute. Otherwise, we're going to go.
I have a quick question. So what barriers did you guys have in this implementation? Like, what was the hardest thing in getting people to do this?
I think the hardest part of this was convincing surgeons that this was safe. Plenty of data show that the rates of cross-reactivity, especially between first-generation cephalosporins and penicillins, is minuscule and quite low. And there are studies that demonstrate that use of second-line agents is actually associated with increased adverse events like anaphylaxis. And so I think getting everybody together, the infectious disease doctors, the pharmacists together, and really making this collaborative document to say this is safe and this is first line and this is the standard of care at our hospital was the biggest pull.
Very nice work.
Thank you.
Thank you. Next, we have Alyssa Vaughn.
Thank you for the opportunity to present our research. Here are relevant disclosures. Pediatric acute respiratory distress syndrome exerts a substantial disease burden with significant morbidity and mortality, and respiratory infection is the most common etiology. Unfortunately, current treatment is largely limited to supportive care. The central features in the pathophysiology of ARDS include overwhelming and unrestrained inflammation and oxidative stress, which create a vicious cycle. CNP miR-146a is a free radical scavenging cerium oxide nanoparticle conjugated to the anti-inflammatory microRNA 146a, and we therefore hypothesized that CNP miR-146a would decrease inflammation in an infectious MRSA-induced model of acute lung injury and ARDS. To test this, we used an existing model, murine model of infectious lung injury. Our experimental design consisted of initial injury with MRSA or saline control at time 0, treatment with CNP miR-146a or saline control at 4 hours, and sacrifice at 24 hours with collection of bronchoalveolar lavage fluid or BALF and lung tissue. Pictured here are our ELISA results for the BALF protein concentration of pro-inflammatory cytokines IL-6 and IL-8 as markers of alveolar capillary breakdown and protein leak. Control mice are in blue, MRSA-infected mice in red, and CNP miR-146a treated mice in green. We found that MRSA infection results in significantly increased levels of IL-6 and IL-8, and treatment with CNP miR-146a significantly decreases these levels back to control. We then evaluated histological changes, including inflammatory cell infiltrate represented on the top row and collagen deposition on the bottom row. We did not find a statistically significant increase in these with MRSA infection compared to control. However, we did find that both statistically significantly decreased after treatment with CNP-miR-146A. In conclusion, CNP-miR-146A decreases bronchoalveolar pro-inflammatory protein leak and may improve histologic changes in a MRSA-induced model of lung injury, and therefore has promise as a potential therapeutic for the treatment of pediatric ARDS. Thank you.
Thank you. Questions?
It's a nice study. How's the HA get to the Is it intravenous?
Intratracheally, yeah, both injury and treatment.
We are recording this, so when you go to ask questions, if you guys could use the mic so that people at home can hear too. Okay, thank you, guys. We are skipping to number 4, so that'll be John Marquardt.
Hi. How do I go back? Sorry. I'll just continue. Thank you for the opportunity to present our work. We have no disclosures, and our study is related to whole genome sequencing and gastroschisis. So despite an increasing incidence, the etiology and pathogenesis of gastroschisis remains somewhat elusive. Multiple studies have shown there is an increased risk of familial recurrence in those who have been affected, which shows that there may be a genetic component to this. Our aim was to use whole genome sequencing to evaluate this genetic contribution. We obtained samples from 4 gastroschisis patients and their families, including 2 sets of monodi twins, and each family contributed at least 4 samples. The affected proband, the unaffected sibling, and unaffected parents, with some families being able to give significantly more family members for this. Whole genome sequencing was performed evaluating for single nucleotide variants, copy number variants, and insertion deletions, specifically looking for those that were more prevalent in those affected than those unaffected. For our results, we found 6 mosaic single nucleotide variants that occurred noticeably more in the probands at 12 to 50% compared to 0 to 21%, and 2 deletions that were with larger a length of nucleotides deleted in the probands compared to those unaffected at 4 to 21 compared to 0 to 4. Below, you can see all 8 of these mosaic variants with their gene location, their frequency or deletion length, and their presumed function. In conclusion, this is the first instance of whole genome sequencing using gastroschisis, which identified potentially associated genetic mosaic variants. Further confirmatory testing is underway, as well as plans for additional study using a much larger patient cohort through the biobank being built by the GOOD study, and plans to include epigenetic studies as well. Thank you. I'll take any questions.
Hi, nice work. Kathy Hunter, Oklahoma. Were there any clinical features that were correlated with the various genotypes?
There were not any specific clinical features, and we did look at all the genes that were affected, and none were specifically related to, let's say, somatic muscle formation or blood vessel inflammation, or things that, at least in the past, have been considered to be etiologies. So there was not.
Thank you very much.
Thank you.
Moving on, we have Andy Dorn.
Thank you for the opportunity to present. I'm here on behalf of the Sphere Lab. So short bowel syndrome is a syndrome that is increasing in prevalence and poses a devastating cost and lifestyle burden on patients and their families. We believe the human intestinal organoids, which are a type of tissue-engineered intestine, have promising therapeutic potential to treat short bowel syndrome. These are derived from human pluripotent stem cells and lack an enteric nervous system, but we can overcome this by co-culturing them with enteric null crest cells. We hypothesize that by innervating them in this manner, we can enhance their mesenchymal development. So these are cultured in vitro for 28 to 40 days, at which point they're harvested and transplanted in vivo into the kidney capsule of an immunocompromised mouse. They're then harvested from the mouse at an earlier or a later time point. Here's an example of our immunofluorescent imaging, and on the far right, an image of human small intestine for comparison. And when we look at the innervated organoids, we find that they have much nicer organization, particularly the muscle. It's arranged in orthogonal layers with a nice layer of ganglia in between. When we look at fluorescence intensity, we find that for the older innervated group, we have a significantly higher actin A2 readout, which is our smooth muscle marker, than the 2 younger innervated and non-innervated groups. At the top left is an example of how we do our muscle grading. We grade from 0 to 3 for presence and robustness of muscle, with grade 3 representing the most robust orthogonally layered muscle. The trend that we're finding emerging from this is that the organoids that are more mature and innervated tend to have higher grade limits. At the bottom left, we have a two-way hierarchical differentiation of selectless and mesenchymal genes, and we find from this that they tend to cluster by age and by presence of enteric nervous system. And at the bottom right, we took a look at hierarchical distant. They are each individually significantly distant from the youngest non-innervated group, with the most significantly distant being the oldest innervated group. From this, we can conclude that innervation does have a positive influence on the mesenchymal development. And we're looking forward to interrogating what the functional difference is. Thank you again.
Nice work. Questions?
That was a great talk. Alan Goldstein from Mass General. I was just curious if you looked at the types of neurons that are in these organoids. Do they form, are there different subtypes? Are there glia included? And can you parse out what's actually in there?
Yes, so for that, I would love to refer you to our poster. In that, we go more into the SIP syncytium. I'm not sure, can I go back on this?
Can we go back one slide?
We'll go back one more additional slide. So when we look at our immunofluorescence, we use a c-KIT marker for our interstitial cells of Call and a TUJ1 marker as a general pan-neuronal marker. So for that effect, we're just looking generally at neurons. But the way we're kind of looking at this is through the paradigm of the SIP syncytium, which describes the interplay between the different cell types that make up this enteric nervous system function.
Hi, David Hackman from Johns Hopkins. That was really beautiful, and
Yeah.
the data is very clear. I'm wondering if this may shed some light on why patients with Hirschsprung's disease are so prone to inflammation, and whether in your gene array you found any inflammatory changes in your various different groups.
That's not something that we looked at, but I do think that'd be an interesting future research direction.
Yeah, it's really cool. Thanks.
Thank you. Next, we have Dr. Nikhil Shah.
Bit of a change of pace, but I think appropriate given the Twitter buzz we got going on here. Thanks for having me. The social media footprint within academic surgery is expanding rapidly, asserting itself as an avenue for applicant recruitment, patient outreach, and surgical education. Its utility across many specialties has been well documented. However, its use within pediatric surgery has not been studied. A list of 51 U.S. pediatric surgery fellowship programs were obtained from the APSA website at the time of study. Active social media accounts on 3 platforms, Facebook, Instagram, and Twitter, were identified. The use of social media by pediatric surgery programs was compared to that of other surgical training programs, including general surgery, otolaryngology, orthopedic surgery, and plastic surgery. Posts from all accounts were then analyzed to determine what was being posted by each of these accounts. Overall, 4% of pediatric surgery programs had active Facebook accounts, 2% had active Instagram accounts, while 45% had active Twitter accounts. Facebook had limited utilization by pediatric surgery, as did Instagram. However, there was similar utilization across all programs by pediatric surgery compared to all other training programs. When looking at the posted content, research and conferences, faculty accolades, and department outreach were the most commonly posted, while applicant recruitment, OR, and clinical activity, gender, and ethnic diversity were among the least commonly posted. So overall, Twitter is the most utilized platform within pediatric surgery graduate medical education. It's highly interactive and promotes a closely knit, impactful community. However, clearly there are opportunities for innovative growth and expansion for applicant recruitment, program diversity, and trainee education and simulation. Thank you.
So did you look at guardrails that the institutions place on the surgery programs? Like at my institution, we're not allowed to have one.
That's a great question. No, we did not. This was just a cross-sectional study to look at what was out there at this time, but I think deeper studies would be warranted to see what restrictions are there and then try to work around those restrictions to help promote the field and the training programs themselves.
Thank you. Now we have Dr. Catherine Snyder.
Thank you for the opportunity to present. We have nothing to disclose. So necrotizing enterocolitis is a devastating gastrointestinal disease of premature neonates that is associated with a hyperinflammatory state. We wanted to study this association and hypothesize that patients with NEC will have an elevated hyperinflammatory response at baseline compared to those without NEC. To study this, we collected tissue from infants undergoing intestinal resection and created enteroids. These enteroids are made in our lab, and they actually retain memory from patients that we culture them from. After making the enteroids, we then perform PCR and ELISA to study hyperinflammatory markers TNF-alpha and IL-8. In doing this, you can see on the first half of the graph, we have enteroids that are made from tissue with NEC, and on the last half of the graph, we have enteroids that are made from tissue without NEC. The blue represents my control, and the red represents enteroids that were treated in lab. And by treated, I mean we subjected them to LPS and hypoxia to induce in vitro NEC. When analyzing this, we can see that there is an elevated expression of TNF-alpha and IL-8 when comparing our NEC enteroids that were treated compared to our NEC enteroids that were not treated in lab, and when compared to our control enteroids that were treated in lab as well. To take this further, we wanted to explore what enteroids obtained from a patient that has fully recovered from NEC expressed hyperinflammatory-wise, and we found that there was an elevated expression of TNF-alpha even post-recovery in these enteroids with similar results when comparing NEC enteroids that were treated to NEC enteroids that were not and to our control enteroids. This shows that our enteroids generated from neonates with NEC have an increased hyperinflammatory response in response to NEC-inducing stimuli, and that our enteroids generated from neonates with a greater degree of prematurity have an increase in inflammatory markers. In addition to that, we were able to show that enteroids from neonates that have fully recovered from NEC do retain that tendency towards a hyperinflammatory state even post-recovery. This may be correlated with an infant's proclivity to develop NEC, and we believe further research could lead to potential strategies to identify infants at risk. And I will take any questions. If you want to see how we make enteroids, that QR code will take you to a video of us doing that. Thank you.
Thank you for a very nice talk, Gail Besner from Nationwide Children's. Were your non-NEC, what diseases did the patients with non-NEC have? And were they age matched to the NEC patients, or tell us a little bit more about that? Thank you.
Thank you. We had a variety of diseases in our bank. We use like gastroschisis, jejunal atresia, and we get control enteroids from that. And then as far as age matching, I did do both. For the majority of my studies, they're all age matched. For one in particular, to assess prematurity, I did not age match those ones, but these results that I showed you today were all age matched.
David Hackman from Johns Hopkins. This is really beautiful work and very translational. It's very interesting that after NEC, there's still a hyperinflammatory state, which probably surprised you. Do you think this may provide some guidance as to whether patients, even though we think they've recovered, may have subsequent NEC if we don't feed them or if we don't manage their microbiome properly?
Mm-hmm. Thank you. I do. I'm actually really excited about this, and this is where I'm taking most of my study going forward. I have performed these studies again in a different infant that recovered, and it's showing similar results, so I do think we need to pursue this pathway further.
Yeah, it's very interesting. Thank you.
We could have that one more. Kathy says we can have one more question.
Okay. Agostino Piero, Toronto. Thank you very much. And very, very nice study. I wanted to ask you, we also look at, in the same patient with NEC, a different level where you take the samples. So if you're closer to the perforation or you're farther away from it, close to where you would do a stoma or a resection anastomosis. Mm-hmm. Have you looked into this phenomenon? Because we found a difference also within the same patient.
Thank you. We also have looked into that with our intestinal specimens, and there is a difference in inflammatory markers we've seen there. Also, we do have a harder time growing our enteroids if they're right from the very diseased portion of the intestine too.
Very nice work. Thank you. Now we have Evan Chernoff.
Thank you to AVSA for the privilege of presenting. Preterm infants are at risk for developing respiratory distress syndrome, RDS, with associated increased inflammation and decreased alveolarization. Our group has previously shown that the NLRP3 inflammasome regulates inflammation. We therefore hypothesized that the NLRP inflammasome will be associated with increased mortality in a preterm piglet model of RDS. For our methods, preterm piglets were delivered at 85% of their 115-day term, equivalent to a 25-week human infant. At this age, there is a marked reduction in surfactant, and all piglets require mechanical ventilation. Piglets were instrumented, mechanically ventilated, and resuscitated for 24 hours or until earlier death. They were then divided into survival and non-survival groups. Survivors here are listed in blue, and non-survivors listed in purple. Non-survivors all died by hour 11, whereas survivors lived the full duration of the study. Non-survivors had a statistically significant increase in expression of NLRP3 as compared to survivors. Non-survivors also had decreased ventilation and oxygenation. Notably, there were no significant differences between the two groups in terms of hemodynamic stability, fluid requirements, and ventilation requirements. In conclusion, oxygenation and ventilation were associated with survival. The NLRP3 inflammasome was upregulated in the piglets that did not survive the study, and the NLRP3 inflammasome may represent a target for modifying morbidity and mortality associated with RDS and prematurity. This would not have been possible without a team effort. Thank you. I'll take any questions.
Hi, I'm Mecklin. I'm from Nationwide Children's. Just a quick question. We also do some work in a piglet model, and I know they're incredibly sensitive, and it seems like your piglets are more premature than ours. How can you be certain that what you're looking at is actually RDS and not any potential? It seems like you sneeze on these piglets funny and they're going to die. How can you be so confident that what you're looking at is RDS and not something else? Thanks.
Of course. Thanks for the question. So in order to create a clinically realistic picture of RDS and prematurity, it's hard to isolate any of the other comorbidities, and especially to make sure that what we're actually looking at is a change due to NLRP3. That said, we try to follow all clinical standards in terms of dealing with the pigs, in terms of how a NICU would handle all premature infants, and we made sure that they were all hemodynamically stable until they were moribund and about to pass away. But good question, yeah.
Yeah, we're a little bit familiar with this model, but not in this degree of prematurity. So this is fascinating. So if your sow has 18 piglets, do you have 18 ventilators?
Yes. Well, we choose the number ahead of time, how many we'll have, and then any piglets delivered after that would be controls. But yes, there's a whole NICU set up in the room, so they're all little beds for all the little piglets. Yeah.
A lot of ventilators.
Yeah, a lot of teamwork. So
It's impressive. Thank you. Next, we have Jennifer Castle, potentially my long-lost cousin.
Married into the name. I don't know about you.
No, this is my maiden name. We'll figure it out later.
Okay. Hi, everyone. Thank you for having me here to discuss our group's work. I'm Jen Castle, and I'll be presenting or discussing the inhibition of deoxynucleotide triphosphate synthesis as a method for sensitizing neuroblastoma to radiation. So radiation is already used in the treatment of high-risk neuroblastoma, but its efficacy is suboptimal. Radiation works by inducing DNA damage. So if you can repair the DNA that's been damaged, you can imagine it's not going to work that well. At the very crux of all DNA damage repair are these molecules, DNTPs. When this pool is high and they have plenty of these molecules, all damaged DNA can be repaired and the tumor can go on to proliferate. Because these are so vital to cell survival, they're actually created in two different pathways. You have the de novo pathway, which is relying on the enzyme RNR, and you have the salvage pathway, which is relying on the enzyme DCK and ATR. So we hypothesized that if we can inhibit these two pathways for synthesis of DNTPs using an RNR inhibitor and an ATR inhibitor, we can sensitize neuroblastomas to subsequent radiation therapy. To test this, we use two different cell lines, a MYC-AN amplified cell line, BE2C, and a non-amplified cell line, SKNSH. For our RNR inhibitor, we use triapine, and for our ATR inhibitors, we tested three different inhibitors, AZD, VX, and BAY. And what we found out first is that based on proliferation assays, all four molecules did work well and are cytotoxic on their own. But of the 3 ATR inhibitors, BAY was the most cytotoxic with the lowest IC50 in both cell lines. So we continued with triapine and BAY as our optimal combination. Using synergy modeling, we found that the combination of triapine and BAY had an anticipated synergistic combinatorial effect in both cell lines based on positive values. With adding radiation, we actually found that triapine with radiation was no different than triapine alone on colony formation. However, BAY did greatly reduce colony formation when it was added with radiation. And then finally, with Western blot analysis, we found that the combination of triapine and BAY with radiation induced greater apoptosis based on cleave-PARP expression in both cell lines compared to single therapies alone. So in conclusion, based on these results, we found that using triapine, an RNR inhibitor, and BAY, an ATR inhibitor, with radiation, we greatly sensitized neuroblastoma cells to subsequent radiation therapy in a synergistic manner. And this represents a potentially novel treatment strategy for a challenging childhood cancer, but does merit further in vitro and in vivo investigation. I'll take any more questions.
Any questions on that? They're wowed by it.
Got him.
Everybody go look at the poster. Next we have Gabriel Ramos Gonzalez.
Good afternoon. Thank you for the opportunity to present our work. We have no disclosures. The aim of our study was to assess weight for age Z-scores at birth as a predictor of 30-day surgical site infection, SSI, in term neonates undergoing surgery within the first 28 days of life. The NSQIP pediatric database was queried from 2018 to 2020 for patients born at or more than 37 weeks gestation who had surgery during their first 28 days of life. Weight for age Z-scores at birth were calculated using the WHO formula. The primary outcome was 30-day postoperative composite SSI. From the 9,136 term neonates included, 5.8% develop an SSI. Neonates who develop an SSI were younger and had higher proportions of being inpatient and undergoing non-elective cases. The mean weight for age Z-score at birth for this cohort was significantly higher. Factors associated with the development of SSI on univariate analysis are seen on this table. After adjusting for variables, multivariable analysis showed non-elective cases, pre-op SIRS, and operative time were independent predictors of higher odds of developing a post-operative SSI within the 30 days. Weight for age Z-scores at birth above 0 or below -2 also resulted in increased odds of developing postoperative SSI when compared to neonates within the Z-scores of -1 to 0, with neonates having a Z-score of over 2 being those at highest risk. In conclusion, positive or extremely low Z-scores at birth were associated with higher frequencies and odds of developing 30 days postoperative SSI. Thank you. I'll take any questions.
Hi, Allison Spear from UT Houston. Great study. The Z-score is obviously a little bit different for babies with like IUGR or Down syndrome. Does the NSQIP account for those differences in these babies?
Correct. It does not, and that's also kind of one of our explanations for our study. Kind of the main driver being those above 2, whether what's in any maternal disease like maternal diabetes, that might account for these babies that are the ones developing higher incidence of SSI. Our further studies are going to look at not using the Z-score at birth, but Z-scores at the time of surgery, and accounting for that period where we see variable weight after birth.
Okay, nice work. Obviously there are limitations with these kind of large database type studies. How are you planning to drill down and find what modifiable factors you might be able to affect change for example, timing or administration of antibiotics? So next steps.
Yeah, I think the next steps for our study is also drilling down on what are the particular surgeries that are being performed on these different cohorts, and definitely extending this analysis for babies from 28 days to 60 days, as we can see then a different array of surgeries being performed, and interesting to see what's going to come out of that. Obviously, at that point, we would then use more the Z-score at the time of surgery rather than at birth.
Nice job. Thank you. Next, we have Dr. Mahmoud Al-Basiri.
Good afternoon, everyone. Thank you for the opportunity to present our work on the implementation of traumatic brain, on the role of traumatic brain. Oh, sorry, I'm gonna start again. Yeah. Good afternoon, everyone, again. Thank you for the opportunity to present our work on the role of TLR4 inhibitor following traumatic brain injury. Okay. So traumatic brain injury leads to inflammation and glial cell activation. Directly after injury, the DAMPs released by the damaged neurons activate the toll-like receptor on the surface membranes of the microglia and the astrocytes, promoting more inflammation and a vicious cycle. In our experimental design, we used the controlled cortical impact model to induce injury in the brain mice, and then we injected C34, which is a TLR4 inhibitor. Then we used various experimental techniques such as PCR analysis, immunofluorescence staining, brain MRI imaging, and behavioral assessments at various time points following injury. Our results showed that toll-like receptor 4 inhibition attenuates the secondary neuroinflammatory response as evidenced by a reduction in the expression of the inflammatory marker interleukin-1 beta and the apoptotic marker BAD, in addition to a reduction in the expression of the astrocyte pro-inflammatory markers, as well as an increase in the expression of the astrocyte anti-inflammatory markers. Then we used brain sections to stain for GFAP and MBP to visualize astrogliosis, which is astrocyte activation and myelin restoration. And our results showed that TLR4 inhibition promotes early astrogliosis on post-injury day 1 and promotes myelination on post-injury day 7. Finally, we used the Morse-Water Maze test to look for cognitive outcomes after injury. During this test, the mice is allowed to swim in opaque water for 60 seconds, and it's directed by different visual cues to find the hidden platform submerged under the water. So 1 week following injury, our results showed that C34 treatment decreases significantly the escape latency time for the mice to exit the maze and find the hidden platform. And then 4 weeks following injury, the C34 treatment increases the number of platform entries of the mice. So apparently they look smarter. In conclusion, TLR4 inhibition increases myelination and improves neurocognitive outcomes. So TLR4 inhibition is of a great therapeutic potential to attenuate the secondary inflammatory response after traumatic brain injuries. I want to thank everyone who helped with this work, and I'm happy to take your questions. Thank you.
I have a quick question. So is that swimming around to find the platform a standard kind of mouse smartness assay? Because I never did that kind of work.
That's a part of our, it's mainly focused on learning and memory for the mice using this test.
That's lovely.
Yeah. It's funny how they move.
That was a great talk and a really interesting topic. I just have a question about the inhibition of TLR4. There's some evidence that inflammation in the brain is a trigger for neurogenesis. So is it important to balance? If you shut down all inflammation, would you prevent recovery from injury? And have you looked for a neurogenesis?
Yeah, so I couldn't present all my data with this short talk. So we have looked at inflammation at various time points, acutely at post-injury day 1, and then at day 7, and then at day 28. So it looks like the inflammation is the greatest directly after injury, and the chronic activation of all the cells in the chronic phase will lead to worse outcomes.
Dr. Pierre, our last question.
Fantastic work. Thank you very much. Did you look at different area, different zone of the brain? Because you have an effect on memory, for instance. Did you have more an effect on hippocampus, for instance?
Yeah. So our main focus was looking at the changes surrounding the lesion site and not around the hippocampus. And we have more data on my poster. It's number 51, and I'm happy to talk more about the topic.
Very good.
Thank
Fantastic.
you.
Thank you.
Thank you.
Thank you. Great work. Next, we have Ashlyn Whitlock.
Good evening, and thank you for the opportunity to present our work on transamniotic fetal immunotherapy. We have nothing to disclose. Secretory immunoglobulin A, or SIGA, it binds bacteria on mucosal surfaces, enhancing mucosal immunity. Higher levels of intestinal bacteria bound by secretory IgA has been proven to be protective against necrotizing enterocolitis. We sought to determine whether secretory IgA administered prenatally via the Traffitt method could bind intestinal bacteria throughout the postnatal period. To do this, 38 fetuses from 4 dams underwent volume-matched intraamniotic injections of human SIGA on gestational day 19. They were allowed to spontaneously deliver on days 22 and 23, and the pups were survived for 1 to 2 days postnatally, before their intestinal contents were procured and submitted for flow cytometry analysis. Specimens were stained for both bacteria with cyto-GFP and for human-specific secretory IgA with PE to prevent cross-reactivity with rat maternal secretory IgA they could have ingested. Secretory IgA bacterial complexes were identified in all samples, with all time points showing significantly higher positive PE events than unstained controls except for 6 days post-Traffitt. The proportion of bacteria bound by IgA decreased daily from 45% to 30% at 4 and 6 days post-Traffitt, respectively, and declined from 36% to 31% bound at 1 to 2 days after birth. The highest percentage of bacteria in a single isolate was 84% and shown here. In conclusion, transamniotic fetal immunotherapy with secretory IgA leads to functional IgA that can bind bacteria in the intestinal lumen in the postnatal period. This could become a novel strategy for enhancing early mucosal immunity in pregnancies at risk of preterm labor and potentially protecting the neonate against necrotizing enterocolitis. Thank you, and I look forward to your questions.
Hi, David Hacken from Hopkins. Beautiful work and very novel. And you're probably familiar with Tim Hand's work, where I think they showed secretory IgAs in breast milk.
Yes, yes.
And so I'm curious if you might use breast milk as a screening, source control or to look at secretory IgA-like molecules there to either validate your screens or even as a source.
Right. It actually is our source. So all of the secretory IgA that we injected in this model is derived from human donated colostrum. And so it is the easiest way to get it, to find that conjugated dimer. It's really only available in breast milk, actually.
I see. And the placenta doesn't secrete it naturally?
No, it doesn't. And the neonates usually don't make it until at least 30 days after their birth. And so they're pretty reliant on maternal breastfeeding for that. And then there's new data that's showing that prenatal infants actually aren't making it for more than 30 days, up to months and months after birth because of the immunosuppression that comes with prematurity. And so we know that it's a pretty difficult immunoglobulin for them to come by.
Yeah, it's really cool. Thanks.
Thank you.
Gail Besner from Nationwide Children's. Thanks for a great talk.
Thank you.
So what are your next steps to see if this actually might be therapeutic or beneficial in terms of NEC?
Thank you. I think the real limitation here is the difficulties in the NEC model, in the animal models especially for this specific application. We know that most of the models of NEC currently are reliant on a hyperinflammatory and ischemic response, and then that leads to transmural location of bacteria, whereas really this is looking at the true pathogenesis of NEC, which is prevention of bacteria itself. So we're working on getting Traffitt towards clinical applications with other things with treating in utero infections and also autoimmune hemolytic anemias. But I think that we have to optimize a larger animal model that could actually show this the benefit of prevention of treatment before we move forward towards clinical applications. So I think really playing around with the right model is going to take some time.
Unfortunately, we're short on time, so you're going to have to ask afterward. Go to the poster.
I look forward to seeing you at the poster.
Next, we have Siavash Shariatzadeh. Sorry, Shariatzadeh.
Thanks for the opportunity. This research is about an underlying mechanism of intestinal lengthening due to mechanical force. A spring-mediated distraction enterogenesis is a method that can potentially be a treatment of choice for children with short bowel syndrome. For that, we compress a spring and insert it into intestinal lumen, which can stretch the wall, and it results in successful regeneration of intestine. It is accompanied by increase in muscle thickness, creep depth, and villi height in short term and long term. Primary cilia is a mechanosensory organelle that is essential for intestinal lengthening during embryonic development. It can mediate the formation of circular muscle layer. As we can see in the cilia-deficient embryo mouse model, we cannot see the proper formation of this layer. Circular layer can cause residual stress, which is essential for activation of Hedgehog pathway. Hedgehog pathway can mediate the formation of outer longitudinal layer, which eventually results in elongation of intestine. As we can see here, in existence of sonic hedgehog ligand, we can see the formation of a smooth muscle in outer layer and also expression of PATCH1, a gene, a key protein of this pathway in that region. In the current study, we inserted a spring into ruling model of mice, and we visualized primary cilia, and we observed a significant increase in number of primary cilia, and interestingly, most of them were formed in the muscle layer. Also, we detected increase in the gene expression of the key proteins of this pathway. In conclusion, we can say primary cilia and Hedgehog pathway are one of underlying mechanism of intestinal growth due to mechanical force. I'd like to thank our great team and thank you for your attention. Happy to take any questions.
All right, go talk to him at his poster. We're going to move along to Jillian Jacobson.
Thank you for the opportunity to present this work. Neuroblastoma is an incredibly heterogeneous disease, ranging in presentation from localized low-risk disease to metastatic high-risk aggressive disease that, despite numerous advances in treatment, continues to have a very poor prognosis. In order to better evaluate the differences in these phenotypes, we developed a pro-metastatic murine model of neuroblastoma. Mice received splenic injections of BE2C, MYC-amplified neuroblastoma cells, and upon the formation of hepatic metastases, the mice were sacked, the hepatic metastases were harvested, and then prepared for splenic injection into a new generation of mice. This process was recreated until we developed a pro-metastatic subclone of neuroblastoma that demonstrated an increased propensity to form hepatic metastases. We call this subclone LM2. Cellular lysates were then taken from the BE2C parental line, as well as the LM2 subclone, and sent for reverse phase protein array analysis. And we found that the LM2 subclone demonstrated increased expression of PREX1, or phosphatidylinositol 3,4,5-trisphosphate-dependent RAC exchange factor 1. And while PREX1 has been implicated in cellular migration, invasion, and metastasis in numerous adult cancers, its role in neuroblastoma, a cancer in which about half of children will present with metastatic disease at the time of diagnosis, is currently completely unknown. After demonstrating that the hepatic metastases formed from the injection of the LM2 cell line demonstrated increased expression of PREX1 on immunohistochemistry compared to the BE2C parental cell line, we elected to use the publicly accessible VERST-D clinical database to evaluate whether there were any associations between PREX1 expression and clinical outcomes. We found that patients who demonstrated increased expression of PREX1 had higher rates of recurrence or progression, events, and death, and that they had inferior relapse-free and overall survival on Kaplan-Meier analysis. Therefore, PREX1 may be a novel prognostic indicator and potential therapeutic target in neuroblastoma. However, further studies are needed to evaluate its function and mechanism. Thank you, and I'm happy to take any questions.
You should go talk to her at her poster too. Sorry, we're running short on time. I'm getting looks. Next we have Tyler Leyba.
Thank you for the opportunity to present our work.
So necrotizing enterocolitis is the most common GI disease of the neonate, and its pathogenesis is multifactorial, but involves alterations in intestinal permeability. The ROCK pathway is activated in response to inflammatory agonists and promotes the upregulation of caveolin-1, a component of a lipid raft involved in expression of tight junction proteins. Occludin is a tight junction protein expressed in the intestinal mucosa, and its absence leads to increased leakiness. So we hypothesize that alterations in caveolin-1 may increase the infant's susceptibility to NEC, and knockout of caveolin-1 in mice would lead to increased incidence and severity of NEC. Human intestinal samples were collected and analyzed for caveolin-1 and occludin. Caveolin-1 knockout and wild-type mice were either subjected to NEC-inducing stimuli or used as breastfed controls, and small intestine was harvested. In humans, there was a decreased expression of caveolin-1 in infants diagnosed with NEC when compared to controls. This was confirmed via Western blot for caveolin-1 in multiple infants with NEC and controls. And this was also correlated with an overall decrease in occludin expression in the NEC-derived tissue. After undergoing experimentation, caveolin knockout mouse pups had an overall greater degree of intestinal injury via both gross and histologic evaluation when compared to these controls. Caveolin-1 knockout mice also had an increased incidence of NEC and expired quicker and more often than wild-type mice. Enteroids were produced, and these were exposed to in vitro NEC experimentation. There was a significant decrease in occludin expression in knockout enteroids, and there was also greater permeability in caveolin-1 enteroids when compared to controls. So this implies that in the absence of caveolin-1, this would lead to decreased expression of tight junctions, such as occludin, and an increased permeability, thus increasing the susceptibility of the infant to NEC. Thank you, and I'll be happy to answer any questions.
Really great work, Tyler. Allison Spear from UT Houston. I know you looked at occludin. There's like 40 different tight junctions. Have you looked at any others? Have you found anything interesting? Tell us.
We have. So we've looked at plenty others. I'm currently looking at ZO1, all the different claudins. There have been kind of the inverse relation with claudin 2, which was to be expected. Most of the more significant things that we've seen have been with the occludin because that's one of the surface tight junctions. More of the ones on the basement membrane haven't seen as much of a significant increase or decrease. But there was that interesting flip in the claudin 2 as well. So we're continuing that work with both Western blots, PCRs, everything in both human enteroids and mouse enteroids. So hopefully we'll have more in the coming years for that.
Nice work. Thank you.
Thank you.
Next, we have Dr. Amir Al-Hadidi.
Thank you. We have no disclosures. The process of evaluating pediatric thyroid nodules at our institution was previously inconsistent. There was a minimal multidisciplinary coordination between endocrinology, surgery, pathology, and radiology. Furthermore, we identified a high rate of negative biopsy results, raising the concern for inappropriate selection of patients. TIRADS is a point-based stratification system with a standardized lexicon for characterizing thyroid nodules using ultrasonography. It is validated and widely utilized in adults and is being increasingly employed at pediatric institutions. Our goal was to implement a quality improvement initiative to standardize the radiographic interpretation of thyroid nodules in order to reduce the number of children undergoing unnecessary biopsies, often with sedation. We aim to accomplish this by increasing the utilization of TIRADS and agreement of TIRADS scoring by all radiologists at our institution from a baseline of 0 to 80% and to sustain for 6 months. The interventions implemented to meet our goals included standardized reporting by way of a TIRADS dictation template, standardized acquisition of ultrasound images, the conduction of 2 educational conferences for radiologists and referring clinicians, and we initiated a monthly multidisciplinary thyroid conference. From 2019 to 2021, 218 patients at our institution underwent a thyroid ultrasound. TIRADS was utilized in 0 children prior to the onset of the dictation template. Following creation of the template, utilization increased to 65% over the next 5 months, and increased to, and it was maintained above 90% after the first educational conference. Ultrasound scoring agreement was only 46% prior to the first educational conference. The agreement and scoring reports increased to 71% in the 3 months after the first conference, and further improved to approximately 80% after the second conference, and this is maintained over the next 18 months. Through a quality improvement initiative, Standardization and adoption of TARGETS was achieved at our institution. This may help to achieve a reduced rate of unnecessary biopsies in our children while maintaining diagnostic accuracy for suspicious thyroid nodules, aligning with our hospital's mission to provide the highest quality care in the safest possible environment, with the goal of achieving the best possible outcomes without unnecessary risk. Thank you.
Very nice work. Can I ask you if you had any kind of resistance to doing this from any parts of the people, like parts of the hospital you were educating?
No, for the most part, it was pretty accepted among all.
Okay, then I guess we could all go implement this. Thank you.
Thank you.
Next, we have Dr. Soo-Yun Lee. Dr. Lee.
No worries, thank you. So thank you again for the opportunity to present. There is growing evidence, as we've also heard earlier today, for limiting the use of antibiotics in complicated appendicitis after surgical source control to decrease antibiotic resistance and antibiotic-related complications. As such, we aim to assess the effect of a clinical practice guideline modification where home antibiotics were no longer prescribed to pediatric perforated appendicitis patients. We hypothesized that the patients would receive fewer antibiotics without an increase in adverse events. This modification was put into effect September 1st of 2021. Prior to the change, for the patients that met the symptom-based discharge criteria as seen on the screen, a CBC was sent. If there was a leukocytosis or a left shift, then they would be discharged with total 10 days of antibiotics. After the modifications, for patients meeting the same discharge criteria, they were discharged without checking for leukocytosis and without antibiotics. We studied the patients from 1 year prior to the CPG modifications from August 1st, 2020 to March 31st of 2023 that met the inclusion and exclusion criteria as seen on the screen. Outcomes were adverse events, including post-discharge surgical site infections, 30-day ED visits, and readmissions. In total, 197 patients were included, 108 patients in the pre-modification arm and 89 patients in the post-modification arm. And as expected, the number of patients discharged with antibiotics were significantly lower after these changes. Additionally, while there was no statistically significant difference in post-discharge SSI rate, there was an increase after the modification. There were no differences in the 30-day ED visits or readmissions between the pre-modification group, which is seen in the yellow, and the post-modification group, which is seen in the blue. Overall, we did not see a statistical significant increase in the SSI rates or other adverse outcomes after eliminating the home antibiotics for patients with perforated appendicitis that met the symptom-based discharge criteria. However, the SSI rates were higher after the modification, and this will have to be carefully monitored. Individual centers should monitor their own outcomes and be cognizant of variabilities in the outcomes that are likely driven by local pathogens and population factors. Thank you, and I'm happy to take questions.
So this combined with some of the Utah work I saw earlier is convincing me to not prescribe any. But my question is, did you guys have a specific length of time they had IV antibiotics in-house, or did you just discharge them whenever they were ready?
We discharged them whenever they were ready, and most of the patients got IV antibiotics until the date of discharge, and that ended up anywhere between 3 to 5 days on average.
Nice. Thank you so much.
Thank you.
Next, we have Dr. Jessica Mueller.
Good evening. Thank you for the opportunity to speak. Stem cell therapy represents a potential therapeutic option to replace the missing neurons in glia in Hirschsprung disease. Unfortunately, its success has been relatively limited by poor survival, poor proliferation, and poor migration. Development of the enteric nervous system relies on highly coordinated interactions between enteric neural crest-derived cells and the extracellular environment through which they migrate. We therefore hypothesize that the success of cell therapy also requires a permissive extracellular environment. Our goal is to modify our stem cells to make them behave more like migrating embryonic neural crest cells. We first compared 2 publicly available single-cell RNA sequencing databases, one on enteric neurospheres, which represent our therapeutic product in stem cell therapy, and the other on migrating embryonic neural crest cells. We found 89 extracellular matrix genes to be differentially expressed between the two groups. Agrin, which is a heparin sulfate proteoglycan, and is studied in the neural crest and known to inhibit neural crest cell migration, was found to be overexpressed by our enteric neurospheres. We thought that this could be problematic for the success of the migration of our stem cells, and therefore focused the rest of this project on agrin inhibition. We first performed an in vitro assay where we used a function-blocking agrin antibody and grew neurospheres in culture for 72 hours. And you can see in the top image on the right, the agrin inhibition significantly increased stem cell migration away from the center of our neurosphere. Next, we used a short hairpin RNA lentivirus to silence agrin. The image on the top left, you can see we've successfully knocked down agrin in our neurospheres, and then performed both ex vivo and in vivo transplants. The image on the bottom left shows transplants that we grew on ex vivo gut organ cultures for 7 days and found that agrin inhibition, again, statistically significantly increased stem cell migration following transplantation. Lastly, we performed in vivo transplants by making small laparotomy incisions and implanting neurospheres subserosally in the distal colon, and then sacrificed the mice 7 days later following transplantation. Again, we found that agrin inhibition significantly increased stem cell migration following transplantation. In conclusion, we here have shown a successful modification of our stem cells and their interactions with their extracellular environment to enhance their migration following stem cell transplantation. Thank you, and I'm happy to take any questions.
Dr. Hunter?
Elegant work, lovely presentation. When I think about migration, it sometimes makes me worry about tumorigenic properties. Is that something that you would be concerned about at all with this model?
It's a good question. I think a lot of the genes that we see to enhance migration are often found upregulated in cancer models as well. Agrin specifically has not been shown to be affected in cancer models, but I think it's a good point and something to think about when we looked at 89. I found 89 different genes to kind of examine in the future, and so I think that's something to keep in mind. Thank you for the question.
Yes, James Dunn, Stanford. Nice work.
Thank you.
Have you found that there's any directionality to the increased migration? Because you could just have an increase in overall motility so that they scatter everywhere. But in Hirschsprung's disease, you presumably want to go in a specific direction.
Yeah, so for this model, we did not look at directionality. We only actually transplanted a single neurosphere at a time. And in other research that we've done in the lab, we transplant many neurospheres at once to try to cover an area. But to be able to have a model that could be validated again and again, we just transplanted a single neurosphere. And so basically you see them scatter from the center in all directions. They sort of move circumferentially around the center of the sphere.
Nice work. Thank you.
Thank you.
Next, we have Devin Mandura.
All right. Thank you for the opportunity to present. The social determinants of health have been defined as the conditions of the environment in which we live and work that may affect health, functional, and quality of life outcomes. This is increasingly understood across medical disciplines, including pediatric surgery. However, the data around this issue remains sparse. Our objective was to measure the prevalence of unmet social needs among the pediatric general surgery patients compared to the general pediatric patients. We retrospectively assessed patients who both completed social needs screening and received surgery by our pediatric surgeons. We compared this population against the general pediatric population who also completed screening during this time frame. Our primary outcome was whether a patient reported at least one unmet social need. We then performed bivariate and multivariable regressions to estimate the likelihood of having an unmet social need based on a patient's surgery status. Over the time of the study, which was between 2019 and 2021, there were around 34,000 pediatric patients that were screened for social needs and 342 pediatric general surgery patients that were screened. During that time frame, there were a little bit over 2,000 operations performed, which comes out to about a 16% screening rate in our pediatric surgery population. Overall, pediatric surgery patients were more likely to be Spanish-speaking in the home, Latinx, and not commercially insured, as well as younger, Patients Surgical patients who screened positive for unmet social needs were more likely or were less likely to speak English. Compared to the general pediatrics population, surgery patients overall were 51% more likely to screen positive for an unmet social need. Surgical patients who screened positive did have an increased length of stay on bivariate analysis. However, this was not retained on multivariable regression. So in conclusion, pediatric surgery patients and non-English speakers were more likely to have an unmet social need. Surgical patients, based on this data, may be a population that's at risk for negative disparities in social determinants of health. In our surgical clinics, we should consider universal screening for unmet social needs, and further research from our group is needed to assess for the effect on specific surgical outcomes. Thank you.
Very nice work. Thank you. Dr. Ellen Reynolds.
I would like to thank Dr. Jason Fisher and Julia Metzger from NYU Langone, whose collaboration made this survey possible. I'm excited to present to you the survey results of our APSA members regarding bias in communication among pediatric surgeons. We found that the preferred method of communication among pediatric surgeons who refer and receive referrals was direct surgeon-to-surgeon contact with a personal phone call. In addition, we also found a discordance in care coordination, meaning that 86% of surgeons who received referrals stated that they provided appropriate communication back to the referring surgeon, whereas only 52% of surgeons who had referred a patient stated that they actually received any form of communication. In terms of bias, we found that 20% of our members stated that they were biased towards other pediatric surgeons who practiced at different types of institutions. However, 50% of our pediatric surgeons stated that they experienced bias in regards to other pediatric surgeons practicing at different types of institutions. And in addition, 21 to 30% of APSA members felt that they experienced bias in regards to APSA-related activities, and that the practice type environment was the main driver of this bias. Community-based, sorry, I did not put that earlier. Community-based pediatric surgeons were significantly more likely to experience bias when interfacing with different practice types. Also, as compared to academic surgeons, community-based surgeons were less likely to receive appropriate communication back in regards to a patient that they had referred to higher care. Thus, in conclusion, different practice type environments is a significant driver of biases and disproportionately affects community-based pediatric surgeons. Efforts to lessen this bias should include more equitable representation and inclusion in APSA-related activities and our national organizations, as well as the use of systematic frameworks that promote reliable communication in order to improve our care coordination. Thank you.
Do you see a role for the national meeting being a place where we could bring people together on this issue?
Absolutely.
Awesome. Thank you, guys. Now we have Adrian Rajab.
Good afternoon. My name is Adrian Rajab, and I'm a medical student at The Ohio State University. Thank you for the opportunity to present our work on the production of a new and improved gut-on-a-chip. I have no disclosures. Investigational drug discovery remains inefficient due to challenges with preclinical models. Organ-on-chip platforms can be alternatives to preclinical animal testing for modeling human diseases and developing new drugs. Unfortunately, the prohibitive cost of this technology hampers its use. Therefore, we have developed a novel, improved, and cost-effective gut-on-a-chip system using 3D printing. Our chip consists of 2 channels separated by an extracellular matrix, with the channels connected to culture medium reservoirs. The channels and reservoirs are printed using sacrificial ink, and the channels are covered in a thin layer of extracellular matrix fibrin PEG gel containing myofibroblasts, a major component of the lamina propria. After being embedded in gel, the chip components are cooled to liquefy the sacrificial ink, which yields perfusible channels once flushed. Here, intestinal epithelial cells have been seeded into the upper channel, shown in blue. Endothelial cells have been seeded into the lower channel, shown in red. And myofibroblasts are incorporated in the lamina propria. After 48 hours of growth under static conditions to allow cell adherence, followed by 7 days of rocking to promote cell maturation, we see in this microscopic image the upper channel containing epithelial cells, the lamina propria containing myofibroblasts, and the lower channel containing endothelial cells. Our novel method of gut-on-a-chip fabrication has several advantages. It is cost-effective. The flexibility of 3D printing allows for easy customization. It can incorporate additional cell types, such as immune cells and enteric neurons, for a higher degree of tissue complexity. And it can easily be adapted to other organs or even multiple organs on a single chip. And importantly, it can be very useful as an in vitro model of human disease. Thank you for your attention, and I will be glad to answer any questions.
Very nice work. Thank you. Next, we have Vikas Gupta.
Thanks everyone for sticking around. I know y'all are excited to hear about some diaphragm work. So our objective was to use a rodent model of diaphragmatic hernia to investigate prenatal myocardial hypoxia and metabolism, including therapeutic hypoxia-inducible factor, or HIF, modulation. We used the standard nitrogen model of CDH, in which a time-pregnant dam was injected with both a HIF-2 alpha silencer and hypoxia probe, which is a tissue marker of hypoxia. Pups from 3 different groups were delivered via C-section, and cardiac tissues were then collected for analysis. We found that, first, prenatally, CDH cardiac tissues are significantly more hypoxic than controls. Those data are not in these slides, but you can see them on our poster. We also found that the expression of cardiac HIF-2 alpha was significantly elevated prenatally in CDH pups, and silencing HIF-2 alpha reversed some of this expression. Thirdly, we found that silencing HIF-2 alpha significantly reversed alterations of cardiac metabolism-associated proteins in CDH hearts, specifically PGC1 alpha and PPAR alpha, which are master regulators of oxidative metabolism. In conclusion, we identified that cardiac metabolic gene remodeling related to CDH-associated hypoxia is initiated in utero and may be mitigated via prenatal HIF-2 alpha silencing. HIF-2 alpha may be a key molecular regulator of cardiometabolic gene remodeling in CDH-associated cardiac dysfunction. Happy to take any questions.
Knowing nothing about CDH research, since I'm a gut person, how would you deliver this to prevent the pulmonary hypertension and hypoxia problems?
Yeah, that's a great question, Dr. Spear. There's been a number of different ways that our lab and other folks at this meeting have tried prenatal treatment of CDH rodents. One is transamniotic stem cells. In this model, we used tail vein injections of 3 sequential doses of our HIF-2 alpha silencer using a liposomal transporter. There's also some thought of doing tracheal therapy. One limitation for studying this is the model. These pups are small. The dams, the time-pregnant dams, are bigger, and so we have more options, but there's a lot more to discover about the dosing, the timing, how much to deliver, and when.
Thank you. Next, we have Dorothy Lee, and don't run away after that, because due to a reordering, we have one more after Dr. Lee.
Hi, everyone. Thank you for the opportunity to present our work here at APSA. My name is Dorothy Lee. I'm a PhD student at Dr. Agostino Piero's lab in SickKids Toronto. I'll be presenting on behalf of Mina Yagane, discussing the therapeutic role of human milk-derived miRNA 148A in experimental necrotizing enterocolitis. So our lab and many others have shown that extracellular vesicles, or EVs, derived from human milk protect against the development of necrotizing enterocolitis, or NEC. We have shown that administration of these EVs in a mouse model of NEC reduces the intestinal injury, as shown by histology and the injury score. miRNAs, which are abundantly found in these EVs, regulate many cellular processes. In particularly, miRNA 148A has shown to have anti-inflammatory effects in other inflammatory models. This gave rise to our aim, which is to assess whether the administration of miRNA 148A attenuates intestinal inflammation in experimental NEC. The delivery of nucleic acids in vivo is challenging due to the rapid degradation of nucleic acids. To address this, we have used lipid nanoparticles to encapsulate mRNA 148A to prevent its degradation in vivo. These lipid nanoparticles mRNA complexes are administered rectally through enema in a neonatal mouse. The intestinal tissues were then harvested and imaged, and you can see that the mRNA 148A, which is in green and indicated by the white arrows, was present in the intestinal villi within the terminal ileum. This shows that our formulated lipid nanoparticles can safely deliver mRNA 148A to the intestinal epithelial cells. To assess its anti-inflammatory effects, we administered mRNA 148A in the neck mouse model, and we looked at the expression of pro-inflammatory genes TNF-alpha and TRIF. Both of these genes were significantly reduced upon administration of mRNA 148A, as shown in blue. Our next steps are to advance our understanding of the potential therapeutic effects of mRNA 148A in neck, as well as its underlying mechanism. Thank you very much.
Dr. Hackham?
Hi, thank you, David Hackham from Hopkins. That was really cool. Congratulations. Very difficult experiments, and managing the microRNAs is no trivial task. How specific do you think this is for the intestinal epithelial cells versus the laminoproprial macrophages or lymphocytes that may be contributing to the reduction in inflammatory cytokine expression?
So for our delivery, we actually were able to formulate the LNP, which is the carrier of this microRNA, to specifically target epithelial cells. So this is what we're planning to also optimize further in future to hopefully package the mRNA or customize this lipid nanoparticle so that it can target specifically the epithelial cells.
So that's interesting, not just because you can cell specifically target this, but you've shown that much of the inflammation is epithelial derived and not monocyte or immune cell derived, which is actually a really big finding.
Yeah.
Great work.
Thank you so much.
Very nice job. Thank you. And last but not least in our excellent scientific session is Dr. Brittany Levy.
Thank you all for sticking around. I'm Brittany Levy from the University of Kentucky, and thank you for allowing us to present our work titled The Cost of Diversity, Language Barriers in Pediatric Appendicitis. As many of you know, pediatric appendicitis is one of the most common diagnoses in pediatric surgical care, and unlike the adult diagnosis of appendicitis, it's largely based on clinical history and physical exam. Even in appendicitis scoring systems, elements all include clinical history findings. In cases where the clinical history is an essential component of diagnosis, we wanted to evaluate the interplay of language barriers. Language barriers are a known risk factor for poor outcomes related to medical errors, and they create a communication barrier regarding healthcare literacy and healthcare access. Therefore, in cases of appendicitis, for those with limited English proficiency, they may be at risk for adverse outcomes, higher hospital costs, and increased rates of imaging modalities. We hypothesize that limited English proficiency leads to a higher rate of healthcare utilization in pediatric appendicitis. To evaluate this, we queried our institutional PD NISQUIT for those less than 18 years old who underwent appendectomy for appendicitis over a 10-year time span. This was linked with EMR cost data, and then we looked at the outcomes related to language and healthcare utilization. Overall, we analyzed just over 1,500 patients, 7.6 of which have limited English proficiency, which mirrors our regional population. And when comparing these cohorts, we noted that those with limited English proficiency had higher rates of diagnostic imaging, median hospital costs, they had longer length of stay, and higher imaging costs. In conclusion, patients with limited English proficiency have higher rates of healthcare utilization, and we should all work to remove this language barrier and provide more equitable access to pediatric surgical care in our communities. Thank you, and I'm glad to answer any questions.
Excellent work. So now everyone should go mingle and eat food and drink things and go to the welcome reception, please.